Welcome to our video on other miscellaneous infections. Let's get started. In this lecture, we'll go through infectious mononucleosis, diphtheria, anthrax, nocardiosis, actinomycosis, and mucormycosis. Let's start with infectious mononucleosis. We'll briefly go through the introduction, pathophysiology, clinical features, diagnosis, and treatment for each of these conditions. Let's begin with the introduction. Infectious mononucleosis is an infection caused by the Epstein-Barr virus, commonly affecting adolescents and young adults. The virus has an incubation period of nearly 6 weeks. It's also known as kissing disease, as it's commonly transmitted through saliva. Other respiratory secretions can also transmit the virus. It's a highly contagious disease. Now let's go through the pathophysiology. When a person is exposed to the saliva of an infected person, the virus enters into B lymphocytes in the oropharyngeal mucosa through the CD21 receptor. This is followed by the induction of a B cell and T cell response, which leads to the formation of reactive cytotoxic CD8 positive cells in the bloodstream. These cells are also referred to as atypical lymphocytes and act against the infected B lymphocytes. The infection is usually asymptomatic in young children. Older children and adults often present with fever, fatigue, malaise, and a sore throat due to pharyngitis or tonsillitis. Patients are also at risk of upper airway obstruction due to pharyngeal edema and tonsillar enlargement. Lymphadenopathy is a common finding and typically affects the posterior cervical nodes bilaterally. Some patients can present with abdominal pain as a manifestation of hepatosplenomegaly. Splenomegaly is associated with a possible risk of splenic rupture, which can be life-threatening. Although mononucleosis may present with a maculopapular rash, it's often brought on with amoxicillin use. It's not a drug rash, and it only occurs if concomitant mononucleosis is present. The mechanism for this is not clearly understood. Here's an image of tonsillopharyngitis in a patient with infectious mononucleosis. Notice the bilaterally enlarged tonsils that touch each other. These are referred to as kissing tonsils. EBV can be associated with Burkitt lymphoma, nasopharyngeal carcinoma, lymphoproliferative disease in transplanted patients, and Hodgkin B-cell lymphoma. All right, let's try a question. A 45-year-old Korean man comes to the physician due to recurrent nosebleeds for the last 5 months. He needs to breathe via his mouth because his nose feels obstructed. He denies any recent respiratory infections. He has noticed an unintended 15-kilogram weight loss over the past 4 months. He has bilateral non-tender cervical lymphadenopathy. Nasal endoscopy with biopsy reveals nasopharyngeal carcinoma. Which previous viral infection predisposed this patient to the development of his current condition? All right, this is a Korean man who has recurrent nosebleeds, a feeling of nasal obstruction, unintended weight loss, and bilateral non-tender cervical lymphadenopathy. He is subsequently diagnosed with nasopharyngeal carcinoma. As we discussed in the previous slide, the previous infection with EBV increases the risk for developing nasopharyngeal carcinoma in the future. The diagnosis is based on clinical findings and laboratory tests. The presence of a sore throat, posterior cervical lymphadenopathy, and splenomegaly are highly indicative of infectious mononucleosis. However, some tests should be conducted for confirmation. A positive monospot test is highly specific for the diagnosis. In a patient with an EBV infection, heterophile antibodies are produced in response to the EBV virus, which can cross-react with sheep or horse red blood cells. This results in agglutination and is termed a positive monospot test. Similarly, a negative monospot test is a failure of agglutination, meaning that the serum lacks heterophile antibodies. A peripheral blood smear will reveal atypical lymphocytes of more than 10% of the total lymphocytes, and a serological test is performed if the monospot test is negative in a person with high suspicion of infectious mononucleosis. The test includes the detection of antibodies against the viral capsid antigen and nuclear antigen of the EBV virus. All right, moving on to treatment. Contact sports must be avoided for at least 3 weeks to avoid the risk of splenic rupture, as this can be life-threatening. Symptomatic management includes acetaminophen for fever and IV fluids. All right, let's try another question. A 28-year-old rugby player comes to the physician due to severe fatigue for the last 2 weeks. He has also noticed a sore throat. His physical exam shows exudative pharyngitis, posterior cervical lymphadenopathy, and hepatosplenomegaly. His vital signs are significant for a temperature of 38 degrees Celsius. He asks to be given medication because he needs to practice for an upcoming match. What is the best recommendation for this patient regarding his occupation? This rugby player presents with severe fatigue, sore throat due to exudative pharyngitis, posterior cervical lymphadenopathy, and hepatosplenomegaly. This is a classic presentation for infectious mononucleosis. Although he's a rugby player, he needs to refrain from any contact sports, including rugby, for at least 3 weeks in order to avoid traumatic splenic rupture. Okay, now let's move on to diphtheria. Again, we'll cover the introduction, pathophysiology, clinical features, diagnosis, and treatment. Diphtheria is caused by a bacteria called Corynebacterium diphtheriae. It's a gram-positive, club-shaped bacillus with metachromatic granules that are composed of phosphate. Transmission commonly occurs via respiratory droplets, but it can also occur via contact with infected open lesions. However, this is a rare mode of transmission. Okay, moving on to pathophysiology. Bacteria invade the respiratory mucosa and release diphtheria exotoxin that's encoded by the beta prophase gene. This causes ADP ribosylation of elongation factor 2. EF2 is an important protein for protein synthesis, specifically in the elongation process of translation. Therefore, the inhibition of EF2 leads to the inhibition of protein synthesis, ultimately leading to cell necrosis. Systemic dissemination can lead to demyelination of nerves and damage to the myocardium. Patients may also present with pseudomembranous pharyngitis, which is a typical feature of diphtheria that occurs due to local effects of the toxin. It appears as a grayish-white membrane over the tonsils and posterior pharyngeal area, which are formed of dead and necrosed cells. An attempt to scrape off the membrane can cause heavy bleeding. Patients may also present with a swollen neck, which is termed a bull neck. A bull neck is caused by cervical lymphadenopathy and soft tissue swelling, and this increases the risk of airway obstruction. Here's a classic picture of a pseudomembrane in a patient with diphtheria. Notice the grayish-white membrane over the left tonsil, soft palate, and base of the uvula. Here's a picture of diphtheria in a child showing a bull neck. The swollen neck can result in stridor and airway obstruction. It can also result in systemic dissemination and cause myocarditis, arrhythmias, and polyneuropathy. The diagnosis is confirmed by the culture of a specimen from the nasopharyngeal swab. On cysteine tellurite agar, bacteria are seen as black colonies. Loeffler medium demonstrates metachromatic granules, which are molecules that contain phosphate within the bacteria. Lastly, an ELIC test is done to detect diphtheria toxin. Here's a picture showing metachromatic granules on Loeffler medium. The treatment of diphtheria begins with the isolation of the infected patient to prevent further transmission. Symptomatic treatment should be done along with airway support, such as early intubation or tracheostomy. Antibiotics are used to control local infection and also in cases of systemic dissemination. IV or oral erythromycin or intramuscular penicillin G are often used. Passive immunization with diphtheria antitoxin neutralizes unbound toxin. Therefore, it's administered early in the disease course. And finally, the diphtheria toxoid vaccine is available for prevention. Okay, let's move on to anthrax. Again, let's begin with the introduction. Anthrax is an infection caused by Bacillus anthracis, which is a gram-positive spore-forming bacillus with a poly-D-glutamate capsule. Transmission occurs via inhalation following exposure to the pathogen or spores from an infected animal or animal products. Inhalation of bacteria or spores results in pulmonary manifestations. Human-to-human transmission is rare. This microorganism has also been used for bioterrorism in the past. Cutaneous symptoms occur when the spores inoculate in the skin. The pathophysiology of anthrax can be summarized as germination of the spores inside the body, followed by multiplication of bacteria and systemic spread of the infection. The bacteria secretes anthrax toxin, which contains edema factor and lethal factor. Edema factor causes cell edema, and lethal factor induces cell death. Pulmonary anthrax is also known as Wohlsorter's disease. Initially, it may present with flu-like symptoms such as fever and myalgias, but later it may progress to hemorrhagic mediastinitis, which can be life-threatening. When the spores enter the alveoli, they're phagocytosed by the alveolar macrophages and taken to the mediastinal lymph nodes where they release toxins. This causes hemorrhagic mediastinitis, which presents with symptoms like fever, chest pain, shortness of breath, hypoxia, and shock. Cutaneous anthrax occurs when bacterial spores germinate in subcutaneous tissues. Skin findings begin as painless papules that form vesicles and later ulcerate, forming black eschar. Black eschar is a typical finding of cutaneous anthrax and presents as a painless necrotic ulcer with edematous borders. It's often accompanied by painful regional lymphadenopathy. Here's an image showing black eschar in a patient with cutaneous anthrax. The central part of the ulcer appears black or necrosed, and the surrounding area appears edematous due to the toxins released. All right, let's try another question. A 57-year-old male farmer comes to the physician due to a skin lesion on his right hand. He noticed a raised bump 3 days ago, which turned into a fluid-filled lesion. Physical exam shows a vesicle on the right dorsal hand and right tender axillary lymph nodes. What is the most likely progression of this patient's skin lesion? All right, this farmer presents with a vesicle on his right dorsal hand with ipsilateral tender axillary lymph nodes. Given that he probably has direct contact with the livestock, he likely has cutaneous anthrax. The papule and vesicle of cutaneous anthrax usually progresses to the painless black eschar with a necrotic and edematous border. The diagnosis is confirmed by culture and microscopic examination of specimens. Specimens that are examined include swabs from vesicles or eschar for cutaneous anthrax and respiratory secretions or pleural fluid for pulmonary anthrax. On examination, anthrax bacilli have a medusa head appearance due to the long interlacing chain pattern of the bacteria. X-ray or CT scan of the chest reveals mediastinal widening and hemorrhagic pleural effusions in cases of hemorrhagic mediastinitis. Here's a chest X-ray showing a widened mediastinum. Note that this can also be seen in many other conditions, such as aortic dissection, and thus is a nonspecific finding. The treatment for anthrax must be initiated immediately. A single oral antibiotic therapy with fluoroquinolones or doxycycline is sufficient in cases where systemic dissemination is absent. A combination of IV antibiotic therapy and antitoxin therapy is required for cases with systemic dissemination. Antitoxin therapy like raxibacumab and anthrax immunoglobulin neutralizes toxins. Therefore, this should be given early in the disease course. Anthrax toxoid vaccine can also be administered in high-risk populations, such as military personnel. Finally, people with signs of shock also require supportive management with IV fluids. All right, now let's move on to nocardiosis. Let's begin with the introduction. Nocardiosis is an infection caused by Nocardia species of bacteria. These are gram-positive aerobic bacteria with branching filaments and are weakly acid-fast. Nocardia is most commonly transmitted via inhalation of the bacteria. Cutaneous infections occur due to bacterial inoculation at the site of skin trauma. Nocardiosis is a rare infection, and immunocompromised patients are at a greater risk of developing it. Here's an image showing gram-positive filamentous and weakly acid-fast bacteria representing Nocardia species. The clinical features of nocardiosis can be divided into pulmonary, cutaneous, and systemic manifestations. Pulmonary nocardiosis resembles tuberculosis and can present with features like fever, weight loss, night sweats, cough, and dyspnea. Cutaneous nocardiosis may present in the form of cellulitis, a nodule, an abscess, or an ulcer. And systemic dissemination often results in involvement of the CNS. A CT scan typically reveals brain abscesses that appear as multiple ring-enhancing lesions. Here's an image of a brain MRI showing a ring abscess with surrounding edema. All right, now let's move on to the diagnosis. Culture reveals gram-positive, filamentous, and weakly acid-fast bacteria, and it's a confirmatory test. Cultured specimens are sputum, skin biopsies, and CSF. An X-ray or CT scan of the chest can show infiltrates, nodules, cavitations, and abscesses. And a CT or an MRI of the brain may show abscesses that appear as multiple ring-enhancing lesions. Sulfonamides, particularly trimethoprim sulfamethoxazole, is the standard treatment for nocardiosis. Treatment should be continued for at least 6 months. Brain and lung abscesses may require drainage and surgical intervention. Okay, now let's move on to actinomycosis. Again, let's begin with the introduction. Actinomycosis is a bacterial infection caused by actinomyces, particularly Actinomyces israeli. This is a gram-positive anaerobic non-acid-fast bacterium forming branching filaments. Actinomyces are also part of the normal flora of gingival crevices, the female genital tract, and the gastrointestinal tract. Therefore, transmission is endogenous. Poor dental hygiene leads to cervicofacial actinomycosis, and alcoholics can develop pulmonary actinomycosis due to the increased risk of aspiration. Here is a comparison picture showing the acid-fast staining of actinomyces on the left and nocardia on the right. Actinomyces is a non-acid-fast bacteria that stains blue after adding methylene blue, meaning that the initial red stain of carbylfuchsin is removed with the addition of a decolorizer. Whereas nocardia is a weakly acid-fast bacteria that stains red with carbylfuchsin, but does not stain blue with methylene blue, meaning that the initial red stain is retained even after the addition of a decolorizer. Cervicofacial actinomycosis is associated with tooth extraction or dental caries. This form of actinomycosis can present as a painless nodular lesion and can progress to oral or facial abscesses. The abscess eventually drains through a sinus tract, and the discharge is often purulent, containing sulfur granules. Pulmonary actinomycosis develops following aspiration of oral and gastric contents. It may present with symptoms like cough, chest pain, and hemoptysis. This is a histopathological image showing actinomyces bacteria in the center, surrounded by macrophages. These may appear as yellow granules macroscopically, therefore they're often referred to as sulfur granules. Culture and microscopic examination are confirmatory tests for the diagnosis. Specimens are obtained through biopsy of lesions and pus. Examination findings show gram-positive filamentous non-acid-fast bacteria. If a sinus tract is formed, a CT scan is required to track the sinus tract and to detect the extent of the disease. The treatment of choice for actinomycosis is penicillin. Surgical debridement is done for severe cases with sinus tract formation. Okay, let's try another question. A researcher is studying gram-positive rods under the microscope. He observes two different genera of gram-positive branching rods, actinomyces and nocardia. Which characteristics distinguish these two bacteria from each other? This theoretical question focuses on the difference between actinomyces and nocardia. Let's recall that while actinomyces is an anaerobic, non-acid-fast bacteria, nocardia is aerobic and weakly acid-fast. Additionally, actinomyces is found in the oral, GI, and female reproductive tract, while nocardia is found in the soil. Actinomyces can cause either cervicofacial and pulmonary actinomycosis, while nocardia causes pneumonia and brain abscesses. Finally, actinomycosis is treated with penicillin, while nocardiosis is treated with trimethoprim sulfamethoxazole, or TMP-SMX. Finally, let's move on to our last topic, mucormycosis. Again, let's begin with the introduction. Mucormycosis is a fungal infection commonly caused by Mucor and Rhizopus species of fungi. It's an opportunistic infection, meaning has a higher occurrence and is severe when the immune system is weak. Patients with diabetic ketoacidosis, immunosuppression, and iron overload are at a higher risk of being infected. Okay, moving on to clinical features. Rhino-orbital cerebral mucormycosis is the most common presentation. It occurs following inhalation of spores through the nostrils and causes acute sinusitis. This may eventually progress and spread to the palate, orbit, and brain. Patients may present with features of sinusitis like fever, nasal discharge, nasal congestion, and headache. As the infection spreads beyond the nasal sinuses, it can cause tissue necrosis and formation of a necrotic eschar over the palate, nasal mucosa, or the skin surrounding the orbit. This can also cause facial and orbital pain in patients. Pulmonary mucormycosis occurs after inhalation of spores into the lungs and can present with fever and hemoptysis. This is a photograph of a patient with rhino-orbital cerebral mucormycosis showing left orbital swelling and ocular discharge. A mucosal biopsy is the definitive diagnosis. Biopsy findings revealed characteristic broad and non-septate hyphae that branch at right angles. Imaging studies like a CT scan can be done to assess the extent of sinus and orbit involvement. Here's an image showing irregular non-septate hyphae branching at right angles. These are the characteristic features of mucormycosis. The treatment is usually a combination of medical and surgical treatment. For initial therapy, amphotericin B is the drug of choice. A step-down therapy with pasaconazole or isavuconazole is usually required once the patient responds to amphotericin B. Surgical treatment includes surgical debridement of necrotic tissue. All right, let's try another question. A 67-year-old male with chronic lymphocytic leukemia complains of severe facial pain and nasal discharge. He completed his last cycle of chemotherapy 2 days ago. His vital signs are remarkable for a temperature of 40 degrees Celsius. His complete blood count is significant for neutropenia. The physical exam shows left orbital edema, ocular discharge, frontal sinus tenderness, and a black nasal discharge. MRI of the brain reveals a left frontal lobe abscess. What will be most likely found on the microscopic analysis of this patient's nasal discharge? All right, this patient with a history of CLL presents with fever, neutropenia, frontal sinus tenderness, left orbital edema, black nasal discharge, and a left frontal lobe abscess. This presentation is consistent with rhino-orbital cerebral mucormycosis. This is common in neutropenic patients. Microscopic analysis will show broad, non-septate hyphae branching at right angles. All right, let's finish up with a final question. A 7-year-old girl is admitted to the hospital due to difficulty breathing. Her mother reports that she had a fever and a sore throat for the past 4 days, but her breathing got acutely worse today. She is not vaccinated due to parental preference. Her family history is significant for HIV in her father, diagnosed 4 years ago. Her vital signs include a temperature of 39 degrees Celsius, a blood pressure of 110/80, a heart rate of 120 beats per minute, and a respiratory rate of 26 breaths per minute. She is using her scalene and intercostal muscles for breathing. Her neck is diffusely swollen. The oropharyngeal exam shows a gray-white plaque near the uvula that is easily scrapable with a tongue depressor. She suddenly becomes disoriented with a PaO2 of 50 millimeters of mercury, prompts intubation. Which of the following is the most likely diagnosis in this patient? A. Diphtheria, B. Oral thrush, C. Oral hairy leukoplakia, or D. Acute epiglottitis. All right, this is a 7-year-old unvaccinated girl who's presenting with difficulty breathing, accessory muscle use, fever, and a sore throat. Her neck is diffusely swollen, and she has a gray-white plaque near the uvula that is easily scrapable with a tongue depressor. She suddenly becomes disoriented due to severe hypoxemia that prompts intubation. This is a classic presentation of diphtheria, so the correct answer is A. Here's a slide that we discussed earlier that should hopefully remind you of the clinical features of diphtheria. Option B, oral thrush, is incorrect because although thrush causes a scrapable white plaque in the mouth, it's usually diffused rather than localized at the uvula, and thrush is not accompanied by respiratory distress or a high fever. Option C, oral hairy leukoplakia, is also incorrect because although it can cause a white plaque in the mouth, the plaque is usually not scrapable. Additionally, oral hairy leukoplakia also does not commonly cause respiratory distress and a high fever. Finally, option D, acute epiglottitis, is also incorrect because although it can cause hypoxia, fever, and respiratory failure, it's not characterized by plaques in the mouth. So again, the correct answer is A, diphtheria. And that concludes our lecture on other miscellaneous infections.